Developing a higher education curriculum instead teaching for the health, protection and promotion of intellectually disabled individuals. Sexual Health and Strategies, Part 3. Learning Outcomes. 1. Sexuality, Human Nature. 2. Sexual Health and People with Cognitive Disability. 3. Sexuality Education for People with Cognitive Disability. 4. Social Opportunities, Sexual Relationships and Cognitive Disability. 5. Forms of Presentation of Own Sexuality and Identity in Culture. Social Opportunities, Sexual Relationship and Cognitive Disability. The social orientation of people with intellectual disability, ID, affects social interaction and adaptation. So, we are talking about significant moments of socialization of a person with ID. This area is defined in the document Sexuality and Disability, Guide for Partners, published 2015, as follows. Sexual orientation is defined based on the following criteria. Attitudes towards people who are gay, lesbian, or bisexual are changing. Still, understanding sexual orientation or why a person is attracted to the opposite sex, same sex, or both sexes can be especially confusing during the teenage and early adult years. Sexual orientation runs along a continuum throughout a person's life, but it is set at birth. Sexual identity may fluctuate until a person is ready to accept their orientation. Many young people coming to terms with their orientation may not identify as gay, lesbian, or bisexual until they are ready. Sexual behavior may move along another continuum as identity and orientation merge. To enable a person to develop a healthy sexuality, it is important that others nurture the integration of orientation, identity, and behavior into their life. An awareness and understanding of the issues they may face can be helpful. Social skills and sexual relationships influence each other. We find the following areas that are defined on the Better Health Channel website, and we can identify with them. The opportunity to mix with other people of all sexes, sexualities and genders, whether socially, at school or at work, is important in developing confidence and social skills. However, some people with cognitive disability may have fewer opportunities to form social and sexual relationships for a number of reasons, including a lack of privacy, being dependent on others for daily living, a lack of confidence about their physical appearance or ability, less knowledge of how to negotiate relationships and express their sexuality, limited social circle and a lack of social experience, physical and/or cognitive limitations, carers who wrongly think of them as childlike or asexual, and carers who view their sexuality as something to be feared and controlled. A person with cognitive disability may need additional support to explore sexuality in relationships. This can be particularly relevant to people with high support needs, for example, those who live with their parents or in supported housing, or those who need help with communication or personal care. People in these situations may want sexual relationships, but wrongly This may not be permitted by their parents or carers. They may lack the privacy needed for sexual activity. Restrictions at home may lead some people into unsafe or illegal activity, such as sex in parks or other public places. In the document Program of Study Human Sexuality from 2015, basis of subject-specific content, which is divided into categories of knowledge, is defined as follows. They have been determined using 4 reference elements: social changes, the dimensions of sexuality, risk-taking, risk and protective factors, and the motivation cycle. The categories of knowledge include concepts integral to the frame of reference, biological dimension, psychological, affective and relational dimension, socio-cultural dimension, moral, spiritual and religious dimension, ethical and legal dimension, public and community support services concerning sexuality. Social dimensions and sexual relationships. Sexuality, in the context of socialization of people with ID, acquires the following meanings, which are described on the website Better Health Channel as follows. Dimension: body image, cognitive disability, and sexuality. In some ways, society presents a narrow view of how people should look, particularly through the media. A person with cognitive disability may feel less worthy of a healthy sexual relationship because they do not match this idealized image. Talking with other people who have overcome body image concerns or a counselor may help. Dimension: appropriate sexual behavior and cognitive disability. Sometimes, a person with cognitive disability may exhibit inappropriate sexual behavior, such as public masturbation or sex from inappropriate partners. This is more likely to occur when the person lacks more appropriate sexual outlets or has not been provided with comprehensive education about the complicated social etiquette and legal issues around sexual behavior and relationships. Sometimes, police may charge the person with sexual offense. The person may also be restricted in unreasonable ways, such as a man being prescribed medication by a doctor to suppress androgens, male hormones. However, appropriate relationships and sexuality education and behavior training and support are, in most cases, better ways of addressing such issues as these. Unfortunately, some people with cognitive disability may have received the message that any sexual expression is unacceptable. This may need to be addressed before the person can learn more acceptable behaviors. Dimension: contraception for people with cognitive disability. All individuals, including those with disability, have the right to make their own informed choices about which method of contraception they use. To make these choices, people need adequate, accurate and accessible information about reproduction, the purpose of contraception, and their contraceptive options. Some people with cognitive disability may find it difficult to access contraception and other sexual health products and services, especially if they cannot be open with their family or carers about their sexual activity. The contraceptive choices available to a person with cognitive disability may be limited for a number of reasons, including current medication may not be appropriate for use with oral contraception, the contraceptive vaginal ring, the contraceptive implant, or emergency contraception, also known as the morning after pill. The contraceptive injection, also known as Depo-Provera, and contraceptive implant, Implanon NXT, may cause unpredictable bleeding that can be difficult for some women with a cognitive disability to manage. There can be difficulties with insertion of the contraceptive implant. This can be overcome by having the procedure while sedated or under anesthetics. Some individuals have difficulty remembering to take tablets such as the contraceptive pill regularly. This can be overcome by supervised use. Some people with cognitive disability may have difficulty negotiating the use of condoms. It is important to remember that emergency contraception can prevent pregnancy after having unprotected sex. For example, if a pill is missed, a condom breaks, or a person with a uterus and ovaries is sexually assaulted. Emergency contraception is available from pharmacists without a doctor's prescription. It should be taken as soon as possible, ideally within 24 hours of having sex. It can be taken within 24 to 120 hours, up to 5 days, but the longer someone waits, the less likely it will work effectively. It is legal in Victoria for any woman to seek to terminate a pregnancy. All people are entitled to access support and counseling about issues related to abortion. Social and sexual development occurs together through interaction with the family and others. Learning about acceptable ways to behave socially is also learning to behave in sexually appropriate ways. I will now present the stages of social and sexual development in children and adolescents, and tips and strategies for parents and caregivers. Stage: Infancy. During infancy, healthy human sexual development is nurtured through the sense of touch during rocking, feeding, and being held. Tips: The love and warmth a baby feels helps them to develop trust and the ability to give and receive tenderness and affection in later life. Stage: Toddlers. Toddlers are curious about their own bodies and many self-explore through masturbation. Tips: Often parents are embarrassed by their children's curiosity with their genitals, but experts urge parents to avoid harsh reactions. Children can learn at an early age that there are private times to self-explore, such as the bathroom or bedroom. You can distract your child at other times and places that are inappropriate. Discouraging self-exploration around others or in public places, while providing other times to be alone, teaches children early on about the concept of private and public. Use terms easier to understand, such as being alone and being with others. Stage: Early childhood years. During the early childhood years, children begin to learn about how people interact with each other by watching what happens between the people closest to them. Later on, their behaviors may reflect what has been modeled for them. Tips: In some homes, people choose to behave more formally with each other, while in others, affection is freely shown with hugs and kisses. Be aware that these interactions are lessons to your children, are learning about how adults behave in close and personal relationships. Stage: Preschool and early school years. In the preschool and early school years, children generally begin to ask more questions and become more interested in the body differences of playmates of the opposite gender. The curiosity about their bodies and the body differences of others is normal. They understand what it means to be male or female and begin to form ideas about gender roles. Tips: Answer your question Answer questions calmly, using the correct words for body parts. Treat their questions as you would any question about how something works. Use books and pictures for their level that your children will understand. If their curiosity leads to behavior that is socially inappropriate, correct the behavior. Reinforce with stories that describe the use of more appropriate behaviors. Teach your children the differences between personal boundaries with family, close friends, acquaintances, and strangers. It is important to them to understand at a young age that their body belongs to them and that they have the right to tell others not to touch them. Stage: Early school years. Through the early school years, children favor a social interest in either the same gender or the opposite gender. Both are normal. At this stage, activities and games with other playmates will help your children to develop in their social world. Tips: Give your children tasks at home that they are responsible for and involve them in activities outside of the home to help build their self-esteem. Stage: Puberty. Generally, between the ages of 9 and 13, children begin puberty. During this time, they experience a great deal of change physically, emotionally, and sexually. There is rapid bone growth, increased sexual drive, and emotional ups and downs, due in part to the uncertainty about what is happening to them. Tips: Before the changes begin, talk to your children about what they can expect to happen. Many books and videotapes are available to help parents share this information in a way their children can understand. Knowing ahead of time what will happen can lessen fears and confusion and help them to build confidence and a healthy self-image. Listen carefully to your children and allow them to express themselves and their feelings. Help your children to recognize their strengths, focus on them, and develop them. Stage: Adolescence. Following the rapid changes of puberty, adolescence begins. Sorry. This time can be marked with conflict between children and their parents or caregivers. The conflict is often a result of normal adolescent need for more independence from the family. As your child sexually matures, there may be an increase in self-pleasuring behavior. The medical community and many religious groups recognize masturbation as normal and harmless. Masturbation only becomes a problem if it's practiced in public places or if the person feels guilty or fearful about the behavior. Tips: Parents make difficult decisions at this time about how much independence to allow their children. Based on your family beliefs and values and your children's ability, you will need to decide what you are comfortable letting your children decide for themselves. These decisions may include choice of clothing, hairstyles, friends, and some activities that they do alone, such as visiting the doctor. These are all opportunities for your children to express themselves as individuals and separate from you. Reinforce concept of public and private, and that the appropriate sexuality means knowing the difference and taking responsibility for sexual decision-making. By this stage, your child should also have and understand information about sexual intercourse and other ways to express sexuality, birth control, condom use, and disease prevention, and the responsibilities of childbearing. Stage: Adult. Whether a child has a disability or not, the development stages will follow the same pattern at a slower or faster rate, until the child passes through puberty and adolescence and becomes a sexually mature adult. Tips: accept that even though your child might have a disability, all humans progress through the stages of social and sexual development to reach adulthood. Continue to have discussions with your adult children about the values that surround sexuality throughout the lifespan: intimacy, self-esteem, caring, and respect. A.C. O'Callaghan and G.H. Murphy in 2007 published a research article under the title "Sexual Relationships in Adults with Intellectual Disabilities: Understanding the Law." The authors make the following findings. Results: there were significant differences between the two groups. Adults with IDs had a very limited understanding of the general laws relating to sexuality, e.g., the age of consent, incest, abuse, as well as the law relating to sexuality and IDs, e.g., whether they could have sexual relationships, whether they were allowed to marry, what protection they should expect from the law. Young people without disabilities showed a better understanding, both for general laws and for those relating specifically to adults with IDs. Conclusions: these findings show that there is a need to educate people with IDs about the laws relating to sexuality. It is important for people to understand the law and, given the high rates of sexual abuse perpetrated against people with ID, it is essential for them to benefit from the protection of the law affords. The new law in England, Sexual Offences Act 2003, post-dated this study. It will be interesting to see whether the new legislation is easier for people with and without disabilities to understand. Forms of presentation of own sexuality and identity in culture. The works of art of disabled individuals constitute of a process of aesthetical cultivation of personality in education, nurturing activities, and art therapy. In relation to this intention, it is necessary to define the interdisciplinary terminological solutions in the sphere of arts, special education, art therapy, and fine arts education. The cultivation of a disabled individual in the form of education nurturing activities or art therapy is closely related to the economic and political development of the individual parts of Europe. The level of education of the society has always been a significant factor in cultural development and economic prosperity. The following text deals with certain aspects of chronological events which enabled to include disabled individuals in the main education stream and provide them with appropriate education and the possibility of applying themselves in the society. The growing quality of education changed the society's attitude to disabled individuals, stemming from the local conditions of European regions. Therefore, we are able to map transformation of a disabled individual from a passive subject to interventions to an individual author actively participating in the society. Disabled individuals are not mere subjects of sociocultural presentation, but themselves produce the same and participate in creating the cultural wealth. Amongst impaired personas known worldwide, there are many of those who have enriched the European society in various artistic spheres. The evidence of this is the tale of art history interpreted by the authors who have created it. The already stated concept of culture within disability studies tends to understand the term culture more narrowly. The culture of disabled individuals is strongly associated with the artistic spheres. The theoretical frameworks and the outcomes are considered from the perspective of comparative analysis. As already stated above, the theoretical framework of the sociocultural model of disability refers to the contemporary turning of the paradigm of disability from the subject of support and care into an active participant in the society, that is, an author. The implementation of this socialization process is reflected in events representing the birth of a disabled author as a creator of social values, initially reflected in the culture. This story began to come true at the end of the 50s of the last century through Leo Navratil, who enabled his patients in the Austrian neurological clinic Maria Gugin the systematic fine arts creation of artifacts. At the beginning, his intention was to pursue diagnostic goals. In his ward, El Navratil already recognized artistic talent in some of his patients and decided to work with them intensively by means of psychotherapy. Subsequently, he started to explore more comprehensively the potential relationship between mental illness and art. The theoretical concepts of modern and postmodern art styles, brute art, outsider art, and disability art share the phenomenon of divergence and the socio-cultural model of disability. Thus, they can be the facilitators of inclusive approaches in the society. A disabled individual is a creator of new social values. Inclusive fine arts education of disabled individuals, relying on artistic forms and approaches in education, follows the education formative approaches oriented on the authenticity, creativity, and individuality of an individual in a community. In the sphere of artistic forms, the disability becomes a relevant aspect of fine arts education of persons with disabilities. For example, brute art, outsider art, disability art, etc. Through the forms of fine arts symbolic language, inclusive fine arts education becomes a prerequisite of the cooperative, reflective, creative, and experience-based concept of education for everyone without difference in the common environment. The solutions to art and fine arts education reflected in the inclusion at school can be seen in the spontaneity of the different interpretation of an individual's identity through authentic fine arts education. Art may become an important method of examining the identity and self-realization of a pupil with special educational needs in an inclusive school. Moreover, it may become a positive factor in the development of interpersonal friendly relationships. The diversity of fine arts expressions help to differentiate amongst individual pupils and define their own self-realization. Hence, it strengthens the need for perceiving civil and human rights resonating in the search for self-determination of a teenager. Any pupil may have an exceptional author of his/her artifact with an overlap into aesthetics up to artistic qualities and may be an asset for the group of pupils and students in his or her inclusive school. Creative art therapy presumes that every individual has latent creative forces that need to be broken free to strengthen self-realization. In specific art therapy applications, principal emphasis is placed on an individual's own creative activity. Thus, fine arts production becomes one of the ways of freeing the already stated latent creative forces. Fine arts production becomes one of the important components of the art therapy process within which disordered reactions to environment stimuli are attenuated and healthy reactions are invoked. In the mentally ill, fine arts production may significantly contribute to preventing hospitalization and various forms of deprivation. The therapeutic intervention of such type is rather a matter of ergotherapy.